Hello, everyone. My name is Carla Van Herpen, and I'm a medical oncologist in Nijmegen, in the Netherlands, in the eastern part of the Netherlands, near the German border. And this morning, the Patient Society, Salivary Gland Cancer, did a very special thing for me. And I would like to take you with that because it's for me a special day, because they asked our king to give me an award for what I did for our patient group. And I'm very proud. I'm sorry for this, but I received it 3 hours ago. And now my kids are at home and everyone is there and my family. But of course, I will give my talk to you because I promised to do that. But it may be there's some noise on the background because my kids are at home. And we have, of course, dinner and a little party after I gave my talk to you. So when I'm a little bit confused, I'm sorry for that, but it is because it's a special day. And thanks for the applause. And thanks for all the patients that they asked to offer it to me. And the Major of Nijmegen, he came and it was very special. So, let's start. And due to Emma asked me to give a talk to you and to discuss two things. First, on the ESMO guidelines, because I think you know that we had one and a half year ago, the first US guidelines, the ESCO guidelines, and we were preparing in the meantime the European guidelines. And Emma was involved in it, and my first part of the talk will be on, what was the process on the guidelines? And of course, you can ask questions on that, but I will inform you the way we did it, also together with Emma. And furthermore, the second part of my talk will on the PSMA phase 2 study we performed in ACC patients. So let's start with the guidelines. Well, the guidelines, they are published last year, and with the four of us, so thanks to Vincent, thanks to Alina Skalova, thanks to Christa Hart, and also especially to Emma, we published it, and we are very glad that we have those guidelines for Europe because they were not there. And I believe guidelines are important, of course, for the doctors and medical oncologists and surgeons and then the next surgeons, etc., but also especially for the patients, because then you know the way we believe salivary gland cancer and also adenoid cystic carcinoma needs to be treated. And how does it start? It is a guideline from ESMO and EURACAN. ESMO is the leading professional organization for medical oncology in Europe, and EURACAN is a European rare cancer network. And there are, I'm sorry, not 7 subdomains, but 10 subdomains, and the 7th is head and neck cancer, and salivary gland cancer is the main topic within head and neck, the subdomain of EURACAN. And one of the main tasks we have within EURACAN is making guidelines for rare cancers, because when there are guidelines, it will improve, we think, or we believe, it will improve the diagnostic trajectory, and it will improve the therapy, and at the end, of course, it will improve prognosis. And so we started within EURACAN that we told each other, we need to have guidelines for salivary gland cancer in Europe. And I was asked to be the coordinator, and I asked all experts, 5 to 15 co-authors in the salivary gland cancer field, of course, multidisciplinary. So we had medical oncologists, radiation oncologists, head and neck surgeon, pathologists, radiologists, etc., and of course, patient involvement. And we made a link to the ESMO. And we had 7 steps to do before the guidelines were ready. So the first step was what I told you on the slide before. we involved 10 to 13, 15 international professionals, experts within the field. And step 2 was collect existing guidelines. And we had some in France and we had some in Netherlands, but these were not European guidelines. And then we divided the different thematic sections, and I will show you on the next slide, over the different co-authors. And we have in our guidelines, so we have a small section on incidence and epidemiology, then on diagnosis and pathology and molecular biology. It's more and more important, as you all know, staging and risk assessment. The 4th chapter was on management of local regional disease, and that was written, of course, by the head and neck surgeons, especially, and in part with the radiation oncologist. Then management of advanced metastatic disease, that was the part of the medical oncology and also the radiation oncology. And the last part was on follow-up, long-term implication and survivorship. And especially Emma and I were working on that part. And furthermore, we had a chapter on methodology, disclosure, and all the references. And what is one of the differences between the US and the European guidelines? We were very limited in the amount of words we used, only 12,000, and we were limited for the number of references. So we started with many more references, but we needed to diminish the number. Well, then step 4 was that we collected all literature and write the content of the different sections. Then we collected all different thematic sessions and literature and made the guidelines. And in between, we had meetings to come to consensus on all discussion points if needed. And then we finalized the consensus. And it's good to realize we made this consensus. We started in 2019, and it was during COVID. So discussions on to have consensus on most discussion points was very difficult. But of course, we had a lot of Zoom meetings at the start and Teams meetings at the end. And well, we did it together. And it was very nice. I think I got a lot of energy from the teamwork we had. We really, all co-authors, I think we enjoyed working together. We were a relatively close group. And that adds, that's important, I think, when you're making such a guideline, that you have the energy to discuss the things. And well, at the end, not anyone agreed. There was some disagreement, especially on the follow-up, but we did it and we made it. And also thanks to Emma, as I mentioned before. Furthermore, we made tables and algorithms, and we had team meetings, as I told you before. And of course, within guidelines, you have recommendations. That is in the US guidelines, ESMO guidelines, and in our guidelines. And that is always on levels of evidence. That is on grades of recommendation. And that is on the ESMO MCBS score. And that is the magnitude of clinical benefit scale of anti-cancer therapies, of systemic therapy. And levels of evidence, well, it is from level of evidence 1 to 5. And 1 is that you have randomized controlled studies. And well, we don't have any level of evidence grade 1 in salivary gland cancer, also not an adenoid cystic carcinoma. Then level of evidence 2, it is small randomized trials or large randomized trials with some bias and sometimes meta-analysis. And well, that's also difficult within salivary gland cancer research. Prospective cohort studies is 3, retrospective cohort studies is 4 level of evidence, and 5 are studies without control group, case reports, and expert opinions. And part of our recommendations, as you can see, most are 4 and 5 and sometimes 3. And grades of recommendation, that is, well, how important it is that you are doing what is in the guideline. And from a patient perspective, maybe the way you can ask your treating physician, well, can you do this? Because this is in the guideline. Well, when there's an A, well, everyone will do it. Will do it according to the guideline, I suppose. Because then there's a very strong evidence for efficacy. B is, a little bit less clinical benefit, but generally recommended. C is, well, it is not sure, and it is optional. D is, well, not recommended, and E is never recommended. And so when you look at the grades of recommendation, we have a lot of C recommendations. And well, the timelines, I told you, it started in 2019, and we really hoped to be the first. But unfortunately, I'm sorry for that, and it is not a game, of course, but we would like to be the first, but the US were before us, but it's not a problem. We have the European guidelines, and we are very glad, our team, with it. And we published it in ESMO Open in 2022. And well, not everyone agreed initially or even at the end on all parts. And I will take you with the part which was somewhat problematic. But it's good to know that we believe that we use the guidelines in all expert centers for salivary gland cancer. And it can also be used by you, by the patients. I think that when you have, well, you would like to read, you can read the guidelines, but we are, one of the things we would like to do is that we make, that we translate in the guidelines we have. It is more for the professionals, for the patients. And that would be great if we could do that, well, maybe this year, together with patients. But I believe that it is important to do that. And what was the main part that was somewhat problematic? That was follow-up, the follow-up part. And you know, for adenoid cystic carcinoma, there's always a discussion. And we have put it in our guidelines in the same, in this way. Follow-up may include the use of MRI for local regional recurrence and chest CT for lung metastasis. In adenoid cystic carcinoma, local regional imaging, preferable head and neck MRI with contrast, agent administration is suggested every 3-4 months for the first 2 years, every 6 months from the 3rd to 5th year, and then on an annual basis thereafter. A lung CT, at least annually, should also be considered. MRI scans are the best imaging tool for local regional recurrent disease. A good multidisciplinary recovery program is needed for every patient with salivary gland cancer. And, well, it is not sure. We have not really high-level evidence that it is needed every 3-4 months. And it is all, of course, dependent on the size maybe of the ACC, the site of the ACC where it originated. But by putting it in this way, Emma and I think and believe that you can discuss it with your head and neck surgeon in the follow-up. And we believe that that is important because there are many, many places in which patients with salivary gland cancer and also adenoid cystic carcinoma are not well followed up. Also not for CT scans of the lung, of the chest. And in some parts in Europe, patients, well, they have only follow-up local regional and not for the lungs. And it is not, of course, you can say as patient, I don't want it. And that's, of course, a good right, but you need to be informed, we think. And then you can make your decision well informed to, well, perform a CT of your lungs or not. And then it's up to you. But this is the way we put it here, in the hope that it will help patients to get the good discussion with, well, maybe a head and neck surgeon or radiation oncologist, to have your follow-up, and that you can have the follow-up you want.